So again, my name is Kevin Caskey. I am the Director of Behavioral Health Care and Sud Treatment Services at El Dorado Community Health Center. Here today to talk about strategies for promoting staff retention, team building, and a positive work culture. Thanks for your interest and attendance, both in person and virtually. Definitely a topic that I'm very enthusiastic about, and so I'm very thankful for the experience or opportunity to share with you. Before I get started, just to let you know, I'll be working off slides and some notes, just kind of in combination, but I think it should flow into a cogent presentation today. I definitely encourage questions, feedback, interaction towards the end of the presentation. We're going to have about 20 minutes to do that. So a little bit about me and my background. Again, I'm the Director of Behavioral Health Care and Sud Treatment Services at El Dorado Community Health Center. We're located roughly 45 minutes from here, so we're in El Dorado County, which is northeast, up the hill, so to speak. Rural background, very different, of course, than here in Sacramento. And the department has three components to it. There is the, sorry, okay, I think we got those slides, but anyway, I skipped over something there, but I think you covered it. So our department has three components. The first one, we have what we call long-term behavioral health, which is your long-term psychotherapy, 45-minute visits. We have an integrated behavioral health program, which consists of clinicians that are embedded in our primary care operation. I work for an FQHC, that's what the community health center is. So they do the short-term work, crisis solution oriented work, that sort of thing, brief assessment and referral to longer term services. And then we have our STEPS program, and STEPS stands for Supportive Treatment Empowering Personal Success. That is we like to think of ourselves as an outpatient Sud treatment program now, but at our core, we're an MAT program. So approximately 65% of our patients present with opioid use disorder and receive medically assisted treatment. So with that being said, that'll kind of be a segue into really the focus of the talk today, which is, how to staff for an MAT program, retention strategies. I'm going to talk a little bit about just, my philosophies based on, experience in terms of hiring practices, team building, and that sort of thing. So let me start with a mission statement, really, that relates to, that comes from the STEPS program, which is to provide compassionate, comprehensive, and integrated treatment for individuals with substance use disorders. Also to offer solutions for safe prescribing and the management of chronic pain. There's a certain amount of work we do with patients who present with opioid dependence, just not safe for them to be on medications long term. So we call it, that's a distinct track from our patients who present with OUD. Just a brief rundown of staff composition. We have ex-waiver providers, 2 MDs, 1 PA who works for us on a PRN basis. And we also have a nurse practitioner who works for us on a PRN basis as well. There's a department director, which is me, formerly a program manager. And I'm going to get into the history of our program a little bit because that's going to tie into staff retention and work culture. My role is to oversee the day-to-day operations, ensure fiscal responsibility. I'm also an LCSW, so I still do direct patient care on a limited basis, 10, 12 hours a week. It doesn't always work out too well, but sometimes we just balance these things. We have to. We have 2 RN case managers. They do the chart review for incoming referrals. They do all our intakes, which we now use. The ASAM continuum, we use that software to assess for level of care. That's something we implemented this year. Also, anything pertaining to what would be considered primary care. If they need labs, follow up with a PCP, and make sure to connect the patients to those types of services. We have a licensed alcohol and drug counselor who facilitates our refill groups. She does individual alcohol and drug counseling for patients who are appropriate and wanting that type of service. We have an in-house psychologist. We also have an AMFT who supports our program. They do in-house psychotherapy specifically for the STEPS patients, and they're integrated into our program. And they have an understanding and appreciation for use disorders, of course, and have an understanding of the modalities that are applicable. We also have 2 medical assistants. They prep for the medical visits, prep for refill groups. I have them do some of our data tracking, more in the past than currently. Other roles we have, and we've expanded, I think we have like 6 of these now, support service coordinators. Those would be our, the people that work in the front office. And one of those individuals is actually recently promoted up to a supervisor, and she's kind of on track to be an operations manager, which speaks to upward mobility, which I think is very important in terms of staff retention. So just to give you a little bit about the composition of our program in terms of roles. Now, how do we all work together in a positive manner? And what do we do to retain people? And how do we hire? I think that's really what's at the meat of the conversation. But before we go there, I'd like to tell you a little bit about the STEPS program previously. So a little bit more about me. As you can tell, I'm not from California. I'm from the South. So I moved all the way out to California for this job. And in 2018, at the time, we were known as the Complex Care Clinic. And I walked into a very challenging situation. What I inherited at the time as a program manager was a very, very divided staff. There was a lack of role clarity. I'm quite comfortable labeling it a toxic work culture. I mean, those types of cultures happen, unfortunately. Very low employee morale, a lot of interpersonal conflict, employees with compromised boundaries. I mean, it's one thing to be friendly with our patients, but it's a whole other thing to be friendly Facebook friends and some of these other things I was encountering. There had also been a lot of turnover in program management. I was the 3rd one in the 2-year period. Operating costs were exceeding revenue, lack of policies and procedures. And I want to say this carefully because, we talk a lot about stigma reduction in our field, so I want to be mindful of that. But the program was patient-driven rather than patient-focused. And I'm going to talk a little bit more about what I mean by that. But it was, it was a pretty messy situation. And to be very transparent, I can say this openly now. After about a week, I was considering, leaving. It's like, I mean, fortunately, I was, single and all these things at the time. I didn't move a family out here. I'm like, what have I gotten myself into? But, here I am 4 years later. So when I talked about earlier, I mentioned the interpersonal conflict and the toxic culture. A lot of that stemmed from this deep divide we had in the program with people that were very entrenched on the harm reduction side versus people that were very entrenched on the treatment side. And my role was to find this place in the middle. And I didn't know at the time we were, developing continuum of care and these other things that we talk about now. Harm reduction was still something that was, I think, relatively new as a concept. I can tell you, coming from Tennessee and in the world of residential treatment that was abstinence-based. I mean, Suboxone was something you used in medical detox for a few days. You did not use it on an outpatient basis. And, I found my way to, I believe that there can be, the two can coexist. It's a continuum, but, we can get into that a little bit more into the conversation today. But with the staff, though, it's not that they didn't necessarily, look at each other's views just completely wrong. It's just they were so black and white that, they were just constantly fighting over things. And, it kind of reminds me of today's political background, not to get political, but we're so focused on what people were doing wrong, we don't really take any time to meet in the middle. So, with all that, we had to really work on, kind of coming to the middle and identifying who we were as a program. So, I'll preface this by saying I'm not here to, get into a debate about harm reduction versus abstinence-based treatment or anything like that. But what this is really about for anyone who's maybe encountering a similar situation or you're starting a new program is you have to figure out who you are, as a program and what your scope is. And for us, and this was really the mission of the organization, was that they wanted to be treatment focused, but also have an appreciation for harm reduction, implement certain elements of harm reduction into what we were doing, but we weren't going to be harm reduction focused on an exclusive basis, if that makes sense. So we had to have people that could work within, in that type of framework. If they couldn't, they weren't going to be a fit. So that was kind of step one towards getting to where we are today, which I think is a pretty good program in terms of employee morale and so forth, and patient outcome. So with all that, we really had to kind of look at personnel, who, like I said, who was going to work, who was not going to work. If a person lacked the ability to kind of be flexible, for instance, that just wasn't going to work. And that can work for both sides of the equation. If you were really entrenched in treatment-based modalities and felt that everyone should work towards abstinence, we weren't going to work for you. But if you, again, were really just focusing exclusively on harm reduction, that wasn't going to work either. So that helped us kind of decide how to hire. And, we did have people go, in different directions after, we cemented our identity, and that was just part of it. So in the earlier days of my time as a program manager, we did have a lot of turnover, but we were expecting that. As the years have gone on, our turnover has not been bad at all. I can't quantify it right now, but from a qualitative perspective, we've had one person leave in the past year for good reason. They just wanted to work from home on an exclusive basis, and it wasn't necessarily on bad terms. So we haven't had to do a lot of rehires in recent years, but when we do, we really try to promote and practice team-based interviewing. We do a lot of situational interviewing. A question, we'll ask is, do you think this is a disease or a moral failing? I think most of us in this room would agree that it's a disease, but we've done some interviews where we've gotten the answers that, well, I feel it's moral and you have a choice. Well, obviously, that's not going to work. And it's not so much about trying to prove that person wrong or convert them or win them over. It's just, hey, you're just not going to be a fit for who we are and what we're doing. And, I talked about the harm reduction focus and the abstinence-based focus. What we go for in our model is we look for, people who obviously have an understanding of the disease. We don't want any patient to feel stigmatized, but we also want people with boundaries. And, it's been my experience that people get into this field for all sorts of reasons. And sometimes, even though they're not necessarily getting into the field for the right reasons. So just like we need to, be very open with our patients, be very patient-centered, really understand what it is they're wanting out of recovery. We also need to have boundaries and, be able to practice good boundaries in the workplace. I think otherwise that's where, burnout and just, high stress situations occur. So, when we do hire, again, it's team-based. We ask a lot of situational questions. We're very clear about our program model and who we are. And, another thing is we don't necessarily have to have people that have all the technical experience on paper that you might want. And I want to be clear about what I'm saying. Obviously, you need a registered nurse to be a nurse case manager. However, we recently made a hire from someone who had worked in the primary care setting, but had a strong interest in what we were doing. And we felt from a personality standpoint that they would be very good. You know, someone flexible, adaptable, someone that could be a good team player, someone that was open-minded, someone that we felt, you know, in a year or two, best practices will probably shift what we do. We need you to adapt and move along with that as we do it as a program. So, you know, that's kind of how we think when we hire. And again, you can't hire an accountant to be a therapist or anything like that, but I think you get my point about personality. So just, you know, I've talked to you about our multidisciplinary team. We have this very integrated treatment model. You know, effective communication is a very foundational component of our program. We have team huddles that start every clinic day where we discuss the patients coming in. It's like roundtable discussion, quite a few curbside huddles to discuss situations that are critical, require, you know, urgent action. Again, I've talked about, you know, hiring for personality and cultural fit. Something else I want to emphasize here is equal but different roles within the program. And that's something I've always tried to emphasize, whether you're a medical assistant, a doctor, or in my role, you know, as someone who moves big pieces in the program and has fiscal responsibility and you know, kind of makes bigger decisions. That's just my role. And it's you know, dare I use the word democracy that we've created within our program. Now that has its downsides sometimes, because, you know, one pitfall to that is sometimes you have individuals who might want to get out of a role. But when you've made the roles very, very clear to individuals and, you know, you have policies and procedure in place, when those sorts of things happen, you can address it from a place of clarity and policy and procedure, and it's a lot less personal. And, you know, if some sort of performance improvement need comes along, you know, it can be about, you know, like I said, role clarity, policy, procedure, that sort of thing. And I think it makes performance improvement conversations go a whole lot better and feel a lot less personal when we can approach it from that standpoint. Something else I just want to, you know, talk about, particularly when we're, you know, discussing retention and you know, positive culture, is really just upward mobility and professional development for staff members. You know, that's, we were talking about C's earlier, so I'm gathering there's probably some clinicians in the room, but, you know, we have our C's and we do the best we can to go to, you know, conferences and learn about best practices. But if your life is anything like mine, you kind of get bogged down in your day to day and you don't always have time for that. But what I've discovered, particularly with support staff, and more specifically for us, our front office staff, you know, they really, first and foremost, from my experience, I can't stress enough the need for continuity with your support staff. High turnover in support staff is not good. It does not lend itself well to operational continuity. So, you know, I'm in a position to be in the leadership team of my organization, so always advocate for the highest wages possible. Try to get those competitive market rates. You know, we're a nonprofit, sometimes we have limitations. But I think if individuals have a sense of upward mobility, such as, hey, I come and work hard for a year, there's going to be an opportunity for me to advance. I mean, you're going to get buy-in from them. And actually, someone who's with me today, Amy, who's currently our front office supervisor, you know, I'll tell you a little bit about her career track. I mean, she worked front office in the Kaiser system for like 15 years, really bright individual. I think just kind of got stuck in sort of that front office mode. And I'm not saying there's anything wrong with that at all, but she wanted more. She just didn't quite know how to get there. And I kind of sensed that she was someone who would be very good with analytics and data. And then of course, SOAR 2 came along, and everyone knows about GIPRAs and all the, you know, all that stuff. I'm like, I don't have time for this stuff anymore. I need someone who can do spreadsheets and track cost and other things for me. So she became a data analyst for specifically for me to support these grants. And then that kind of expanded into our department. Worked out really well. Well, a year later, you know, I needed a supervisor for the front office, and needing an operations manager as we get, you know, bigger and bigger in our department. Again, there are 3 components to our department, including the MAT. So, it's just an example of someone who kind of started at a ground level, or ground floor position, if you will, and worked their way up. But what I've really tried to instill in her is, hey, do this for your support staff as well. So I think that's really important to do with support staff. Again, nurses, MAs, and so forth, they're kind of locked into a position, but that doesn't mean you don't offer the opportunities. And, of course, another thing in this day and age is flexibility. I'm sure we have some parents in here, and, you got daycare costs and all these other things. So really try to, promote a reasonable amount of flexibility in the workplace. So those are some things that we've, a little early for questions and discussion. I've got a few more things to discuss, but anyway, some of the things that we've done, and that's really just been my experience on what works. Some other things that I wanted to touch on in talk today is just really, I think this is going to touch on the pandemic and the burnout that we've seen in our field, and some of the struggles that this field has had, or the behavioral health, mental health field in general has had in recent years. Compassion fatigue and burnout and vicarious trauma are things that I think we talk about from a very academic perspective. I know it's something that I learned a lot about in my grad school experience, but it took some challenging work experiences for me to really learn how to put it into practice personally, and then really sometimes you have to force it in the workplace, and because I think we're all guilty of working ourselves to death, particularly in this field. We're most of us are very empathic, caring individuals, and part of that, I think, is just really promoting boundaries in the workplace. And within the STEPS program, our average roughly not roughly, actually, it's actually pretty close. We average like 15 patients a day. And there are other programs that I know average a lot more than that. And I'm not saying that that's wrong. I'm not saying it's right. I'm not saying it's wrong, but it's a sweet spot that we have found. Economically, it works for us. Obviously, having grants helps with that. But, caveat with being that we are an FQHC, we do have a nice reimbursement. But also just try to look at it from a not just an financial place, but what about emotional economy? What can you do emotionally, and how do you avoid burnout? So we found 15's a pretty good number. I mean, we try to keep it between 15 to 18, and there are situations that arise where we have staff members who slip with boundaries a little bit. I mean, we're all subject, for my therapist in here, we're all subject to issues of countertransference, and we can all have feelings that we're maybe over-identify with the patient, or maybe we just don't like the patient. I'll be completely transparent. I have patients that I don't like, that I treat. I just don't like them. And, and that's just, I think that we can be afraid to have that level of honesty and vulnerability, because again, I don't want to send the wrong message out, but we're very anti-stigma focused right now. And my concern with that is I don't want it to go to an extreme where we don't know to set personal boundaries anymore. And I've had a situation, and I got to speak about this in pretty generic terms, but I've had another situation in another area of our operation with another individual outside of the STEPS program that didn't know to set certain boundaries. And while well-intended, it really put the patient at risk. Can you hear me okay? Sorry, I thought it was fading out there. So, it's just kind of a reminder of, how we've got to find balance in all this, and we have to find balance in the work that we do. And when we talk about, retention strategies and the positive work culture, I think we need to promote that. And, I've always tried to keep an open door policy. And if someone is feeling burned out, stressed, needs time off, I'm like, go do it. In the hospital, I think they say get off the floor or whatever, the nurses or whatever, just because you can't really take care of yourself, and you're at that point where you've lost objectivity. It's not going to help anybody out. And at the end of the day, I guess my two main goals as a as a department director, one, to provide excellent patient care, and to two, have just, an excellent workplace where people want to come to work. And I don't think that can be accomplished if we're pushing without boundaries or limitations. And, we have to not be afraid to speak up and say, well, this has gone a little too far. We've got to have some boundaries in place, which kind of circles back to, what I was talking about with having a patient-centered program versus a patient-driven program. Because in the field that we work in, if you're constantly reacting to an emergency, you're going to always be in crisis mode. There's always going to be an emergency going on. So what I feel we've done in the STEPS program is trust me, it took a few years and it took some change, is, we learned how to, manage emergencies and manage crises from a team-based perspective. It's a collaborative effort versus those situations managing us. And I'm very willing to be wrong, but I think managing the emergencies and the crisis are a better way to go, because when everyone's in a good place emotionally, able to get to that place of objectivity. And when we talk about patient-centered care, as in, what is it that you're wanting out of treatment? Well, you want residential, that's an option. Or, hey, you're not ready to, you're not ready to quit, but we want to keep you safe. Here are test strips. So that way, for us anyway, we've been able to, I think, successfully plug into a continuum of care where, we're in the middle, but that doesn't mean we don't operate and work with other sides of that continuum in a cooperative manner. And that's not to say that we don't have situations that arise that, require us to kind of look internally and, modify roles. That would be another, suggestion I'd have for anybody is, job descriptions are, that's a working document and they evolve over time. I can assure you my job description 6 months ago is not the job description it is today, and it'll look very different in a year from now. So, that's just where we have to really be adaptable. And, there are times where, even with personnel, we sometimes have to repurpose them and find other roles with them that are based on strengths, because you can change and adapt and modify, and sometimes people just don't fit the model anymore. And that's not a bad thing. It just means that there's going to be a different place for them. And, for us, what that's looked like, I typically people who don't work well for us are people that there was either a pre-existing issue with them being too rigid, or they just got too rigid because they couldn't roll with the changes, if you're familiar with that, REO Speedwagon song. So anyway, with that being said, that's really what I have on my presentation. I hope it was helpful and meaningful. I mean, I think we've got a little bit more time than anticipated. Is that we're good? Okay. So open up to questions, discussions. Okay. Yeah. Yeah, sure. So for those, through here. Okay, that's, yeah. Just so you can, hear me virtually. Yeah. I'll go with this one. So the question in the back was, if I could be more specific about, collaborative efforts in crisis-oriented situations and what that looks like for us. I think she specifically asked for an example, and I can give a very recent example of what that looks like for us. So we had an out-of-county referral that came to us with, I'm going to use DSM-4 or vernacular here, but polysubstance use disorder. I mean, we thought it was just OUD and we would induct and stabilize, but it turned out to be, a multitude of benzodiazepines, alcohol, just high risk. This was not a patient who was ready. She wanted to continue use of benzodiazepines. We ran a cures, number of things that just, raised some concerns. So in situations like that, we always want to evaluate risk. I mean, from an organizational standpoint, I mean, there's also the behavioral intervention. Hey, we want to keep this person engaged at whatever level they're willing to be engaged in. So that's where, behavioral health comes in, just someone to be objective, be, like an advocate, if you will, for that patient. And then you have the doctor, and then in that particular situation involved me just to kind of be briefed in on it. And then our, drug and alcohol counselor as well, just for added input. So, that's, an example of like a curbside consult where we just try to develop a very rapid approach or rapid treatment plan to really, ensure patient safety from a medical standpoint. I mean, we weren't in this particular situation, we weren't going to continue them on a course of Xanax, but there was, okay, doctors, well, what if I do a long acting taper with the understanding that she's going to have to, come in and, we want to monitor the Librium each day because that can get high risk, particularly if someone's drinking. So there's just, all of us making sure that we're comfortable with that plan and then how we're going to implement it. And because once everyone if you try to do it, we like to do it in person, literally face-to-face huddle, because I don't know about you all, but there's just too many emails these days, emails, Teams, and there's no way to keep up with all that information. So I think when you do it in person, you look, you see each other. I just think it goes a lot better. So that was something else that our patients, we converted over to a telehealth model during COVID, but we all stayed in office because we just felt it was too critical. But that's kind of an example. I mean, we just really identify what players are needed, to participate in the discussion and then make decisions. Of course, document the decisions, but then after the fact, you don't get into he said, she said. I mean, I've got, just as an aside, I've got a situation now it's got this risky situation that happened between behavioral health and primary care, and I've got a multitude of information. We're just trying to sort out fact from fiction. So I think we're all collaborating. It minimizes that, particularly in high risk situations, because in the case of this individual, I mean, we are talking life and death with the nature of her substance use.
From the chat, you don't need to read this.
Okay.
We'll just call it the same person. Are there any recruitment practices and then team building practices you found?
Two very, very good questions. I'll first talk about recruitment. That's one I'm very, very passionate about. So I'm going to switch over to what we've implemented on the behavioral health side. So that particular workforce, as in getting behavioral health clinicians, has become very, very difficult, particularly in areas such as mine. Everyone wants to go into private practice and work from home and make a lot more money, right? I mean, I don't blame them. It's understandable. So we, identified a need to, and this really goes back to 2020, start an internship program. So, and yes, we started an internship program during the pandemic, but it worked out. So, we had and identified, kind of hammered out a role, and then one is turned into like 10, 12 interns. We offer on-site supervision, and we have feeder schools. We do, have an agreement with the Sacramento State and their MSW program, their MFT program, a lot of online MFT programs. So we really promote internships as a workforce development tool. There was a grant opportunity. Some of you may be participating. I say, no, the mentored internship grant, which is AHP is the administrative entity for that. So we secured that grant. We're offering paid stipends. And again, an emphasis on the FQHC model, serving the underserved, serving, our particular, type of patient. Now we have, organizations from all over in different types of settings. So, I would definitely recommend starting an internship program, workforce development program. And with the nature of the MIP grant, it doesn't have to, I mean, you can allocate funds towards paraprofessionals. I mean, we're working on developing front office staff. We're looking at the peer support specialist. That's a role we haven't implemented yet, but we have someone who's interested that's, on a degree track. Other things that I've found effective lately is just with those universities, network, get your brand out there. I mean, I get on LinkedIn, post jobs. Some of this like I said, I moved here from Nashville, Tennessee, so that was a much larger market, but I still took that playbook, of I'd previously built internship programs there and network. And, what I find is those interns turn into employees. And we're actually going to be formally hiring our first intern from the MIP program that I mentioned in a few weeks once she becomes an AMFT. Now, when it comes specific to like ex-waiver providers, we've tried to make inroads with the medical schools and get people to come up and shadow, do rotations with us, get interested in what we're doing. For the FQHCs that are in the audience or listening today, you've got those loan repayment programs that you can build into your you don't offer it as an employee, but you definitely support it and facilitate it. So I think just try to really build a comprehensive and robust package that you can offer. And, we've been fortunate with our grants, so we can, offer some bonuses and some other things like that. Fortunately, we're going to be fully staffed here pretty soon. I mean, I've got one person to interview that I'm pretty confident in, but it hasn't been easy. So those are the things that I found that have worked for me. But at the end of the day, I think I love networking and meeting people. I mean, I got kind of siloed with COVID like everyone else did, but historically I found that to be a very effective recruiting tool. Now the other question, does that answer? Okay. The other question was team building. We've definitely we've had to be more careful with what we promote in terms of gatherings. That's gotten a little better. In years past, we've definitely done Top Golf and some other things to get people together. But I usually with our team meetings, I always like to start, and I actually didn't put this into practice today. It was kind of a larger audience, but usually I like to ask a question about, a movie that you've watched recently or, something we wouldn't know about you. And I think that just kind of helps to break the ice and so forth. And so meetings typically start that way. And I think it just helps to, build a kind of a collaborative spirit. But I definitely encourage, provided your organization doesn't frown upon group gatherings right now, definitely, have team building activities. We certainly will again in the future once we can be a little bit more lax with that sort of thing. Mm-hmm.
So how did you go back to building, going from a staff that was divisive or fitted and trying to build that so that it's not like a holistic?
Great question. It required some very difficult conversations with a couple of individuals who, first and foremost, I had a direct line to the CEO, and that's who I report to, and say this is the program that we want, and they had recruited me specifically for the program that they wanted. So there was the organizational emphasis and support on what we were going to do. So with that divisiveness, it really just got down to some difficult conversations with certain staff members who I didn't feel were going to necessarily fit with the model moving forward. Now, that wasn't day one. I just, anything new, you want to go take that 90-day review and sit back, take notes, look at dynamics, look at who's reacting to who and who's reacting to what. But eventually you start to see the outliers. And when I saw the outliers, it was just the conversation of, hey, this is who we're going to be moving forward. Is this going to continue to be a fit for you? That's a little bit, that's a little bit tricky because, California is a very employee-friendly state, pro-employee. I'm not saying that's a bad thing. It's just, but when you're trying to really manage through some personnel issues, it can be a little bit tricky. But again, it wasn't intended to be anything derogatory or negative or anything like that. It's just, we just want you to be happy with this situation and want to come to work. And that kind of took care of itself. People weren't necessarily buying into what we were doing, and found other avenues. And but it was like a 2-year process, and for the most part, minus one individual who was way too rigid. And it finally just got to a point of untenable because it just wasn't going to work. And that came about 2.5 years in. So it was that long of a process to get through it all. And I'm 4 years into it now. And, I think we're in a good place, but we've definitely submitted our hiring model. So, but was not easy. I can tell you that. I don't know if I'd want to go through it again. Yes. No, I'm good. Come to you.
Could you just give me a brief kind of what website actually, where that comes from? I've heard that most recently, website consultations, and I just never asked, what is that?
Well, yeah, I mean, just so literally just, I might be encountering, I mean, let's just say I'm doing a therapy session, for instance, and a patient reports to me, hey, I was drinking, a fifth of vodka a day and I quit just 2 days ago and I'm shaking, I'm sweating. I'd immediately probably, Teams or contact Dr. Rayner or Dr. Velasquez. And I need to talk to you real quick. Seems appropriate to send them to the emergency room right now. But, I'm not an MD, so I don't want to make that decision. And then it would probably get routed to the nurse. Nurse gets pulled into the conversation. Doctor says send them to the ER. Nurse contacts ER and tries to connect services like that. Another example might be we have a psychiatrist who works for us, and she's exclusively remote now. She moved to Idaho, but still works for us. I consider myself reasonably skilled at diagnosing patients, but she's at a whole nother level. So I might see someone presenting with, a multitude of issues. I'm like, I have no idea how to do a differential diagnosis. Help me out here. So I literally just, ring her up on Teams and say, hey, are you available at such and such time? And, she'll give me some feedback just so I have some guidance in terms of what I'm working with. And I think it's always been there with the program. It kind of came from the huddle that I talked about. But Teams was, for those of you familiar, I think most of you are familiar with Microsoft Teams. We started that. I'm kind of old school. I'm almost border on anti-technology, but Teams is pretty, give me a flip phone, too much sensory information coming in, but, or sensory overload. But anyway, but Teams, we brought Teams into, our workflow and our, just daily operations during the pandemic. And it, we had specific threads for specific clinic days, but it really helped to promote that curbside huddle concept. So, you can do it in person, you can do it by phone, you can do it by video. I prefer in person myself. Now what it looks, another thing that it looks like for me is, I'm way more of an administrator than a clinician now. So things kind of get uploaded to me. It's like, hey, we got a real situation, managers that work under me and, just that sort of thing. It's just really just promoting open door policies and communication, coming out of an age, I think being very, very siloed and, you can get on Google and look up anything now, but I just think it's a lot better to talk to, somebody who has expertise in person. So you had a question?
My question is, how are you, two questions, is the 15 to 18 for provider?
Correct.
14 alongside that?
Correct.
Okay. And then the second is strategies that you utilize. What I think I'm finding in our organization is we had PPP support for the last 2 years during the pandemic, the data protection money. And we don't have that anymore from July going forward. So as a result, productivity went down in residential programs, outpatient programs, and treatment programs. How have you strategized increasing productivity from the results of the pandemic? Because for us, it's somewhat sore in the sense of we didn't lay anyone off during the pandemic. We kept everyone employed, which I'm very proud of. But the flip side to that is now we're increasing productivity and open door access and moving more back to in-person patients, because that's what our patients need.
Mhm.
Do you have any strategies that you can use to kind of overcome?
Well, I just want to make sure I understand your particular setting that you work in, just so I'm answering your question.
We have every level of, we have the whole continuum from control management all the way down to the DUI intervention.
Mhm.
Intervention. So I'm just saying, in general, let's say the NTP program, that's what that relates to,
Mhm.
which is an outpatient.
Yep.
Clients or patients coming in, and then, mainly counseling is a requirement of them being enrolled in a mental health program.
Mhm.
But the state gave us, leeway to give take homes, so their counseling went down because they all moved to like telephone-based counseling.
Mhm. Yep.
So we're increasing productivity, and it's a little challenging to increase productivity with the same amount of staff. Just because we didn't lay people off during the pandemic now. So I don't know if anyone else has experienced that as a result of the pandemic, but that's kind of, we're facing increasing productivity again based on our contractual agreements.
But you don't have the staff to support the product.
We have
The-
staff. I still have the same amount of staff we started with. It went down for the 2 years of productivity.
People got comfortable being less productive.
Yeah.
Oh, got it. Okay, sorry. All right. So I just wanted, yeah. So okay. Very good question. Yeah. Very good question. So again, I like to preface things sometimes when I make certain statements, but I am a therapist, that, but we've got to keep doors open. We've got to be fiscally responsible. We have become very, very metric driven, metric oriented. And I mean, earlier I made that statement, well, we're it's roughly 50. It's exactly 15. And I mean, we have Amy, who I mentioned, we know all our data and all our metrics. And I'm the last person that wants to come down on a provider and see more productive, knowing how difficult that work is. But at the end of the day, there's got to be some kind of threshold that you meet to be, just to be solvent. So based on my experience, and again, just like I said, we're in an FQHC, rich PPS rate, all these other things. So, we're in pretty good shape there, but you got to be responsible with it. And in our other parts of the operation, like behavioral health and the integrated behavioral health program, there were productivity issues there where we've really just had to drill in and say, okay, these are the average visits that must take place each day. For IBH, part of their work is non-billable. We still quantify that. You get it even, but you got to think ahead. You got to think, okay, if X happens, then how are you going to respond? If Y happens. So my recommendation is to become, data informed, metric driven, and hopefully find a place where you can promote best practices, but also promote, fiscal solvency and financial responsibility. And, it's not an easy balance. But the conversation, I mean, and I have those, I have those providers that want to grow and expand and build and want this and want that. I'm like, I want the moon, but we still have to pay for it, And so I want to hear your side of it, but I need you to hear my side of it. This is what it costs, and I can't change that. But what I can do is work with you to try to find some place in the middle. Now, again, we've talked about fit, and you asked a conversation earlier. What good is it if you're going to go broke and shut your doors? I'm not saying that's your situation, but but just in general. So if you are needing to shift to something that's more metric oriented and more data driven, it might require a more difficult conversation. Hey, this is the direction we have to, and it's nothing personal, but we've talked about retention, hiring models, and all these other things, but we have to have a business model in place too. How are we gonna keep everything? Did that answer your question?
Yeah, I absolutely think it's different in the FQ setting.
Yeah.
More fee for service, yeah, but we're all gonna, it'll slap in the face here shortly.
Mm-hmm.
We have no choice but to develop and implement KPIs and performance.
Yeah.
For our providers, it's just a whole new things
Yeah.
that in the substance use disorder sector that aren't like that.
Yeah. And I think one other thing I'll add is just, I mean, it's not always possible, but just to try to send the message out, this is not punitive. This is just what we have to do. But I think having been way downstream, I'm just talking about my earlier days as a, primary therapist, and I worked for Universal Health Services, massive corporation. And, I'm just a little primary therapist. It felt so impersonal. And it wasn't a fit for me. I'm like, okay, I don't ever want to work in a situation where I'm this small again, because I feel like my work's completely irrelevant. I'm not saying that, again, that's your situation, but I think we all kind of have to figure out what's right for us, but both as businesses and as individual employees. So.
I can give suggestions too, because it is a little bit different, but in a way, it's like your first story that I had asked about, because there's a culture change happening, right? So yeah, using sort of the William Bridges transitions model of acknowledging that there was something and that's ending, and now we're in this gray zone, and this is what we're going to, using those metrics so that there's clarity, and talking about the change. And some people are going to be like, you know what, I really liked telecommuting, and if I can't tell it, I'm gonna leave, and that is happening. That creates a lot of workforce challenges for us. But then there's also a lot of people who are like, all right, I have to get back to used to this again. What does this mean? And what does it look like? What are we keeping? So really kind of acknowledging that and building that culture that says, this is where we were, this is what we went through, this is where we are now, this is where we're going. And it isn't, we have to be ready to let go of this part. And it's not just about the money, it's also, this is what we want to be doing to help with that. And then being ready in the fee for service world to have your fees high enough to not have it go all the way back where you were maybe, the productivity levels were so high that you really couldn't do as good a job as you wanted to. Yeah. That would be my suggestion. So that.
Yes.
I had a question.
Sure.
I work in a F2 HC here in Sacramento that's a little bigger as well. And so I'm wondering I guess in our experience also, we learned with the staffing, I really actually had to, while I trained, in doing like the tiered, phase model, care comes in once a week, every 2 weeks, then every 2 weeks, et cetera, et cetera. But when it became kind of the last stops with me, and like the staffing issues, with providers have other duties, the respiratory clinic and this and that, it really did actually push me to take a more individualized approach, with each patient, and then kind of be a little bit more, let the severity kind of reveal itself to me, and then kind of tighten the reins for myself. And I personally, as an addiction medicine specialist, am really comfortable with that. But as bringing in kind of newer providers, some of them are asking, for a little bit more of that, like, can we get like some more of that structure? How do we kind of rectify that with like some of that being tied very specifically to like just straight negative extremes, as opposed to like the visit. And I guess I'm just kind of wondering, since you've kind of been there for a number of years now, kind of your experience like over time, with what has kind of worked best for like the providers and the patients, in terms of like the structure and maybe how that's kind of changed over time for you with the pandemic, and how you're planning for at the end of the public health emergency, like at the end of October, and like transitioning that.
Yeah, good questions. So I too, came in under the phase paradigm, and that, I think that was good at one point in time. We've, no pun intended, phased out of that. We're not phase driven in terms of patients, and so there isn't this. For those of you who aren't familiar with phases, there's phase 1, 2, and 3, once a week, every 2 weeks, and once a month, depending on urine drug screens and a number of other, presenting issues. I guess really for us, with as we evolved into more of a general sub program, really like AUD is a big emphasis for us now, but also those patients that present with, multiple use disorders, including, stimulant use. It's like, okay, their OUD has been stable for a year. Why are we having them come back weekly? Well, it's because of the stimulant use and, negative drug screens. Well, I mean, I don't want to say but my experience has been that's not effective. It becomes punitive. So we shifted away from that and said, okay, well, look, the OUD is stable. That's what the patient wanted. So, we'll see you monthly or see you bi-monthly. If you want to engage in any way on the stimulant use, we have this Wednesday group. Show up, you get a gift card. You don't even have to do a urine drug screen. So I would definitely, when I first started, we needed to really tighten things up and become rigid because the program was bleeding, out. I mean, and just emotionally, financially, and all these other things. So, but then it was like, okay, well, we can't remain this rigid. I mean, we're going to have to, open up a little bit. And so we did move away from phases. And now it's really just it is a provider decision with input from the team. And that comes from those morning huddles. And really, there are it's much more subjective than objective, as in we had the specific criteria in the past. And, I think it speaks to best practices. It also speaks to really what we've found works best with our experiences, and also just addresses, the fact that we've shifted from just, medically assisted for MAT for OUD to a multitude of use disorders. Now, your other question was, what are we doing coming out of the pandemic? I mean, like many of us, overnight went from brick and mortar to telehealth, and that's the way it needed to be for a period of time. But it was getting to a point, specifically with these higher risk situations for new patients, where our providers were not comfortable with phone and video. They wanted to see the patient, physical exam, all these other things. So we got to a point where we're asking all patients to come in person, at least for the initial visit, and then we'll make a determination from there. Stable patients we kept, in the telehealth model, which it looks like that reimbursement's not going anywhere. So I expect us to be somewhere in the middle, really depending on the patient and their presenting issue. I mean, I don't, something like AUD that's really critical, high risk, they're going to want to see that patient in person. Some inductions they might be willing to do, over the phone or by video, but I'd say it will probably 50-50 as I imagine where we'll fall. So.
Quick follow with that.
Sure.
Like the Ryan Page, coming back into effect, the intakes will likely have to add the in-person component of like the telehealth with the follow-ups shouldn't necessarily be. Because I do have a lot of number of patients who can't do the Wi-Fi, but they can use phone.
Yeah.
Those for maintaining like the follow-ups.
Yeah. Yeah. We have the same situation. I mean, people that are way up in the city, they don't have cell phones. So it's, it is phone based. So it's, it's going to be audio. Yeah. I mean, frankly, we're looking at a mobile unit. We might just, have mobile clinics that we drive up and, so that's something we're looking at. Is that, I think you had a minute here.
Excuse me, mine was really quick and it was just
Sure.
a response to what she was saying. And what we had to look at was essentially the diversity of the workload. And so we, as a private practice, we operate as if you're a full-time clinician, you have 6 hours. So that around 24 sessions a week, billable hours that you're having. But we make deductions for different things. And so for those who travel to, let's say, the reservation, that travel time is counted as a deduction. Then we also actively seek out ways in which they can generate additional income. So doing things like presentations or additional trainings are a way that they can generate income and reduce their number of hours. So I don't know if that would be helpful or not, but it's just a different way of looking at, one, how we're doing outreach. It's also part of advertising for our business. And then it's giving our providers a little bit more flexibility and not just session after session. But we also get a lot of the referrals from our tribal communities. So that's something that's worked for us.
I'll just quickly say, and if I'm understanding SOR 3 correctly, it's going to be open to everyone, and you don't. I mean, you don't have to be, nonprofit. So I have taken grant funds and that where we can take a certain amount and put it into our general operating funds. And, we've done, you can't bill Medi-Cal for, you have a group of 6, you can bill for 1 patient, but we've offset operating costs associated with groups that were co-facilitated, again, just sort of take the load off of patient after patient after patient. So I don't know, it's been another trick in the playbook, if you will, is just taking the grant funds and, sort of allocating it in ways that again, to your point, bring in revenue, but take pressure off. So anyway, I hope that helps. So,
This is just the next.
thank you. Yeah, appreciate it very much.